Our first layer of speakers use their roles in government, both federal and provincial, to integrate FASD prevention throughout their government's programs, strategic plans, and policies. We'll begin with Donna Malone. Based in Halifax, Nova Scotia, Donna works as a program consultant and FASD lead with the Public Health Agency of Canada, or PHAC as you probably know it, with provincial, community, clinical, and research partners across the 4 Atlantic provinces. Rooted in her commitment to social justice and equity, she works in the areas of community-based programming, policy, and knowledge exchange. Donna.
Thanks, Linda. I sincerely appreciate the opportunity. I don't know if I appreciate having to follow Nancy Poole, but thanks so much to be here with such great women. So as some of you are no doubt aware, the Public Health Agency of Canada has a lead role as a federal agency responsible for the FASD initiative. My dear colleague Holly McKay is here. Her work is quite different from mine. Holly's team would be focused on funding and managing large projects, trying to reduce fragmentation, bring national leadership, policy direction, best practice. I'm in a region with the Public Health Agency. I'm rooted in community and working, as Linda said, kind of across disciplines. So I want to speak about the context of our work, how we essentially work to overcome that context, which can feel quite challenging at times, and what we feel are our bright lights, or what might be promising for us. So by way of our context, we're working, as Linda said, across 4 Atlantic provinces, teeny tiny provinces in the easternmost part of this country. These are jurisdictions with unique policies and strategies and priorities and politics and leaders and capacities. And certainly capacity and sustainability, or lack thereof, it seems, are often our challenges. Leadership, as is the case across the country, within First Nations and Inuit communities has been a real strength for us. New Brunswick is our officially bilingual province. We're also operating within the parameters of the federal government, priorities and complexities, with competing interests, with questions about federal role in public health and federal provincial jurisdictional questions. And certainly the focus on deficit reduction has meant fewer resources to move around, to bring people together, and to learn, sadly. So these smiley faces, I see my co-chair of this group is sitting here, Danielle Demers, are members of one of our kind of groups within the Atlantic region, the Atlantic Intergovernmental FASD Partnership, of which I'm the co-chair. So this involves folks from coastal Labrador, the ethnic Inuit government of Nunatsiavut, Correctional Service Canada, First Nations Inuit Health Branch, and several departments across the 4 Atlantic provinces. So these folks are advocates within, as we say. They're bringing it up. They're asking questions. They're writing their briefing notes to inform their ministers. They're sharing knowledge across departments. They're providing advice on practice, trying to stay in tune with the evidence. And while that model is not unique, there's FIANO, there's other groups across the country, certainly held up as good practice. Sometimes it can feel that our progress is slow. Key players also would be these national maternal child health programs, which many folks here would be familiar with, the Community Action Program for Children, the Canada Prenatal Nutrition Program, and Aboriginal Head Start, on and off reserve. These folks are crucial players in the Atlantic. They're operating, in our case, in community-based family resource centers, some inner city, but mostly rural, from a philosophy of harm reduction, trying to create supportive, safe environments for women and families, where women often talk about their substance use because that's where they feel most trusted and not judged. And my work in this, in liaising with these leaders, is to really try to give voice within government circles to the reality that women face and the extensive practice-based knowledge of the staff. We have a very tiny community of clinicians, well, not so much clinicians, but certainly of researchers, and we're really trying to support them with resources and opportunities to disseminate, and we're really trying to build trust with clinicians who are working frontline with women. Sharing information opportunities, whether it's the new MD-CME course that Nancy just mentioned, through MUN, the lowest drinking guidelines, telehealth sessions, training on motivational interviewing. Really trying to acknowledge their reality of budget cuts, of pressure to keep wait times and waiting lists short, but also trying to support their practice in being aware of the social determinants of health, social determinants of women's drinking, and what promising clinical practice is available in this area. So, in overcoming or maneuvering our context, multiple simultaneous strategies, we say. So I'm a federal public servant. I fulfill my duties to the government, but I serve the Atlantic Canadian public. That's how I see my work. I serve particularly those who are most marginalized by social and health inequities. My dear colleague from this city, once, several years ago, when I first started out, shared something from Rachel Naomi Raymond that she had written about the difference between serving and helping. And we spent a lot of time, as Holly and I say, feeding the beast. So coughing up information or intelligence from our region to the government. I try to not make that all of my work, right? So I try to serve. We do feel that governments need to be working as to serve the public as equals, and that is sustaining and renewing for me. We operate from a community development framework. We put forward principles of inclusion, participation. There's certainly much cooperation among the 4 Atlantic provinces, but we try to capitalize on the bit of competition that exists between them. If someone's doing something well in Newfoundland and Labrador, we want to tell PEI about that. It's often political. Our work is political. We need to work with it. As you all do, we leverage and seize opportunities where it sometimes feels like there are none. So one gathering fosters another. One ally leads to another. This image is of the cover of a DVD that we produced in Nova Scotia, trying to influence policy and decision makers in our province. So these are the voices of a community leader, a diagnosing clinician, a special needs consultant, our Chief Medical Officer of Health, and Nancy Poole, who just happened to be in our region at the time, and we wrestled her in to also be on the video. And we do try, as Nancy herself says, to walk with those with whom we may differ. We feel that humility and patience can go a long way, staying the course. So yes, we have to have not just patience, but a sense of urgency. 1 minute left, wow. My community partners remind me all the time that government has the luxury of learning, sitting. We need to hurry up in government. We really need to be aware that community is counting on us to do the right thing. What's promising? Research. Our sisters at the IWK Health Center produced this study. It's caused a lot of stir. Clinicians are thinking critically about their practice. Our sisters at the Addictions Research Center with Correction Services Canada, their work is in jeopardy. That's not promising at all. What's promising is that people are rallying around their work and trying to ensure that the issues that they have brought up through the research in terms of women incarcerated, affected by FASD, that their needs are actually going to be heard in a sustained kind of way. David Butler-Jones, the head of our agency, says that public health is local all the time. Lots of local work. The image here, women's lives and women's health, a critical part of FASD prevention, was the first time we went beyond looking at level 1 prevention when we talked to women about their real needs, women who were using during pregnancy. In policy, Nova Scotia has an alcohol policy. New Brunswick has just announced a new Center of Excellence, FASD Center of Excellence. We're really trying to support them with an equity and gender perspective through their work. We're trying to build a supportive capacity and skills. It was a beautiful moment in Charlottetown a couple of weeks ago when Nancy was with us, and a very high-level public health official in the province was asking Nancy and challenging her about dominant alcohol screening tools, and you could see the wheels turning in his head. So it was a really kind of a disorienting dilemma for this fella, and you could tell that these events have an impact on folks who are practicing, and we need to be able to continue to do them. I'll just finish by saying that the connection to the NAT is absolutely crucial to us. We often feel isolated. We feel far behind the rest of the country. We've put the kibosh to that mantra because it's self-fulfilling prophecy perhaps, but it's an extremely powerful network, and we're just feel very privileged to be part of it. So thank you.